Hello and welcome and thank you to Honorary Consultant Neurooncologist Dr Raj Jena for joining me today to discuss Avastin treatment in NF2 care.
It's a pleasure, Jess.
So before we start, it's important for us to mention that we're discussing Avastin treatment in the UK, where there's a specialist NF2 care under the NHS, so some of our content may not apply in other countries. So Raj, Avastin's become a familiar name in the NF2 community, but for the sake of people who don't know about it, we'll aim this podcast at them. So first of all, please could you explain what Avastin actually is and how it works?
Sure. So Avastin is the trade name for a drug called bevacizumab. It's an antibody treatment, so that means it's a protein that's used by our own immune system, and it recognises markers made on our own cells, but also markers that are on foreign cells too. Avastin recognises a marker called vascular endothelial growth factor, or VEGF. Now, this is an important marker that's produced by tumours all around the body because it helps them to grow a blood supply. And what Avastin does is it blocks this marker, so without a blood supply it's much harder for a tumour to grow. Avastin was first used in patients who had very advanced bowel cancer and breast cancer, where they'd received several different types of chemotherapy treatment, and all of them had stopped working. And Avastin, I remember, produced incredible results in these patients, and so it started to be used in a range of different cancers, usually in an advanced stage. It was even used for brain tumours a little as well. So it was about 13 years ago that neurologists in the US who were interested in neurofibromatosis observed that the vestibular schwannomas in neurofibromatosis were very, very good at growing a blood supply in order to help their growth, even though they are benign tumours. So they decided it would be worth trying Avastin on these tumours, and we got very, very good results. That's why we are today.
Okay, thank you. The Avastin is most commonly used to target vestibular schwannomas, but is it ever considered an option for treating tumours elsewhere in the body?
Yes, I mean, as you said, Jess, the main indication is for vestibular schwannomas because these are the tumours that have been found to have the most blood vessels. We do occasionally use it for ependymomas that are in critical locations in the brain, pressing on important structures. And that's important because ependymomas produce cysts filled with fluid, and these can get bigger and cause problems as they get bigger. And we've definitely seen cysts shrinking on Avastin. So those are the main two indications that we use Avastin for.
Great, thank you. So, for the sake of this podcast, we'll stay focused on vestibular tumours, and I'll refer to them as VS to save myself some breath. I understand that there are some criteria that patients must meet in order to receive Avastin treatment, so please could you talk about those terms and why they're put in place?
Yes, so in the UK, to meet the criteria for Avastin that are set out by our specialist commissioning service in the NHS, you have to have either a vestibular schwannoma that grows by 4 millimetres in 1 year, or it has to increase in volume by 60% in 1 year. As I mentioned before, Avastin works on cystic ependymomas, so we can use it for those too. And we can also use it for a schwannoma that is threatening your neurological function as it grows. And those are the indications for which you're allowed to use Avastin.
Thank you. That would make sense. Are you able to give some statistics as to the success rate of Avastin in terms of hearing preservation and VS management?
Yes, I mean, in fact, we published our results from the UK a few years ago. We're seeing overall about an 86% level of hearing preservation across all our patients, And what's amazing is that the rate of surgery for vestibular schwannomas in particular has dropped by about the same amount since we started using Avastin too.
So how are you able to tell whether Avastin is working or not?
Well, we rely on three things: MRI scans to take measurements of tumours, audiometry tests to assess hearing function, but of course listening to what people tell us about the treatment and their symptoms. I think of the three, we probably rely on MRI scans the most because we get objective measurements that we can then write down and use to justify the fact that Avastin is working.
Brilliant, thank you. Now I'm sure this is one of the most common questions that you're asked, and that is, what are the most common side effects of Avastin?
I think it's important to say that generally the side effects of Avastin are mild, and it's good to see that people on Avastin overall get good quality of life. There is this induction phase for the first 6 months when you go on Avastin, and you have to have a fairly high dose every 2 weeks, and that's the period when most people experience more side effects. And the commonest side effects are tiredness, a sore mouth, and it can affect your voice quality, sickness, and some people just they lose their appetite during treatment, and tummy problems, so either diarrhea or constipation. We see both. The other thing, of course, we worry about particularly is if it starts to cause high blood pressure. And for women that have not gone through the menopause, it can also cause problems with heavier periods. We've definitely seen those too. Those are the common side effects.
And are there any other side effects that are less common?
Yes, there's some important side effects that we always need to look out for. Avastin causes the kidneys to leak protein, and we monitor for that very carefully when people are having treatment. There's also an increased risk of blood clots, and I think that's important if we're treating people who are, for one reason or another, less mobile. Very rarely we have seen patients who start to develop heart failure due to Avastin, which sounds very scary, but it's important to remember that all of these side effects get better if you do stop Avastin.
And are there any long-term effects currently known that to continue to persist even when Avastin is stopped permanently?
Yeah, this is something that really worried me in the past when we started treating people with Avastin, but we've now got over 10 years of data of our own for treating patients and to understand about any long-term complications. And there are clearly long-term effects. What we've seen are things like ongoing high blood pressure after treatment, dry eyes, and in women whose periods have been affected by Avastin, that might have been enough to make the period stop completely in some people.
Okay, good, thank you. The hearing preservation is obviously a very positive result of Avastin that helps people to maintain the quality of life. I'm wondering if Avastin ever causes a negative impact on people's quality of life.
It does, and that's going to depend very much on people's personal experience of the side effects that they get. And what I would say is most people manage to get through the 6-month induction period. You've just got to that period of time, and if you can bear the side effects, you know that things will get better. Sometimes I have had to slow things down, and so we've had to give the treatment more slowly, for example, every 3 weeks rather than 2 weeks, often for blood pressure problems. But if you look, we've collected a lot of quality of life assessments, and it shows that in most patients, the quality of life improves really quite quickly after starting Avastin, which is a good sign overall, I think.
Yes, okay, thank you. So in the most part, people are able to adapt to and tolerate the treatment really well. Is there a time limit as to how long patients can receive Avastin for? Should they tolerate it without any major issues?
No, we don't actually have a limit, and this is one of the most unusual uses of Avastin in medicine, where we don't really have a limit. As long as it continues to work, we can keep using it, and I'll say a little bit more about that possibly. We review progress with patients every 2 years in order to check that they're happy to continue. And so at that point, what we do is we say for each person, what are the risks and what are the benefits that we're getting for you from Avastin, and just to kind of, formally check that everyone is happy to keep going. But we don't have an actual limit.
Okay, great, thank you. Is there any evidence as to whether Avastin can potentially affect fertility?
Yes. So we do have evidence that Avastin weakens the function of the ovaries, and they can stop working earlier than they would otherwise do, particularly if you've been on Avastin for a long time. We don't have any clear evidence of Avastin affecting male fertility yet, but we offer patients options for fertility preservation before treatment, both for male patients and female patients. There are options like egg and partial ovary storage that are both possible, but it's difficult because it takes time to do that before you start treatment. You need to have several hormone injections to stimulate the ovaries, a bit like IVF that you might have heard of. So it's not so easy, unfortunately, for female patients. For the male patients, of course, sperm storage is available, and that's a little bit easier. So yes, we do definitely have options.
In that case, is it safe for women to become pregnant or for men to bear the children whilst they're receiving Avastin?
I mean, the guidance we give is that for both men and women, it isn't safe for you to be on intravenous Avastin when you're trying for a baby. So, trying for a baby or falling pregnant, it's not safe.
Moving on, what happens with treatment if someone needs to have a surgery on tumours other than their VS?
So this is very, very important. The thing to remember is that Avastin is stopping tumours from forming blood vessels that they need to grow. But Avastin also stops wounds from forming blood vessels that they need to heal. So that means if you're having surgery on any deep part of the body, you do need to make sure that you've allowed time for the Avastin to wash out completely. We normally allow a month, and then you have the surgery, and then we wait a whole month again after that before starting Avastin again, in order to make sure that wound healing from an operation occurs properly.
That makes sense, thank you. Is that also the case for radiation or gamma knife treatment?
That's a good question, Jess, and I think that's going to depend very much on individual circumstance, the balance of benefit and risk. I mean, generally, radiosurgery and Avastin are used as alternative treatments, and you would be on one or the other. But there are situations where you might want to use both, and in fact, we use Avastin to treat some of the complications of radiosurgery that occur rarely after treatment for other patients. So that would be something really, an individualized discussion with your oncologist and your team, really.
Thank you. Now I've heard of a class of drugs called Biosimilars, and I hear there is one for Avastin. Can you say a little bit more about it and whether or not it's suitable for people with NF2?
Sure, and this is important to me. In a nutshell, I don't think we should offer biosimilars to NF2 patients. So if you remember, the Avastin antibody works by shutting down blood vessel formation in tumours, and that is the intended effect of the treatment. But we also know that Avastin activates the immune system close to those tumours in a way that has an effect on reducing tumour growth. Now, we don't understand exactly how the antibody does this, or which part of the antibody is doing this. So a biosimilar is a new antibody that is designed to be very similar to Avastin in terms of shutting down blood vessel growth, but it is not identical. It's not the same thing. So we don't know how well the new antibody might activate the immune system in the way that Avastin does very effectively. So in the UK, we're lucky. The funding for Avastin has been agreed centrally in the NHS, and we're planning to keep using the original Avastin antibody for our NF2 patients. Elsewhere in the world, though, patients might be offered a biosimilar because of cost. It's so much cheaper. So on the one hand, this might be a good thing for people who have to pay for their medicines in certain parts of the world, because otherwise they wouldn't be able to afford, bevacizumab at all. But on the other hand, we shouldn't assume that it works in exactly the same way as Avastin does.
Thank you, that was very insightful. Coming back to Avastin now, how frequently is Avastin given and how often are people reviewed?
So, as I mentioned before, it's given every 2 weeks for 6 months, and that's what we call the induction phase. Then the maintenance phase, you have an injection at a lower dose every month. And for some patients who are very, very stable, we even switch to 2 monthly infusions. In fact, during the COVID pandemic, we've actually done this for our stable patients just to reduce visits to the hospital. But basically, 2 weeks for 6 months and then monthly after that.
You know what happens if someone's tumours are not responding to Avastin after the 6-month trial period?
So we can continue at that induction dose, and we have done that. It's tough, but people do manage to continue on the 2 weekly infusions. And what's nice is that we have seen responses when we've done that. It just seems that it took more than 6 months of induction treatment in order to get that response.
Thank you. Yes, so this is why I would like to talk to you about your specifically. And I know from my experience with Avastin that making big, tough decisions is a part of the Avastin journey, and our consultants play a fundamental role in supporting us throughout the entire process. So please could you talk about the importance of a good partnership between consultants and your patients, and what you are there to do for them?
Yes, I mean, it's vital to have a good relationship between consultants and patients because, I mean, the nature of NF2 means you're going to have this relationship for a long time. And so it's really important, as you know, that you're going to have to make choices in the future to build mutual trust. I mean, the way I see it is that consultants are here to monitor your disease, to give advice and to offer options for treatment. And when we give advice, it has to be balanced about the risk and the benefit of any treatment. For some things, this is easier because we've got lots of data to base our opinions on, so we feel more comfortable with our advice. But for other things, like Avastin, we've got less data and more unknowns, and this is where the mutual trust comes in. So we as consultants need to be able to trust that you will tell us about anything odd or unexpected that is happening to you, so that we can keep an eye out for those risks. So I think it is very important, as you say.
Thank you so much for that. Now I'd like to talk to you about how and why patients are monitored so closely each time they come to have Avastin treatment. So that includes having a blood test, a urine sample, taking their blood pressure and assessing their body weight. So let's start with the blood test. Please could you explain what you're looking for at the blood test and how the results may affect treatment that day?
Sure. Mainly what we're looking is how the kidneys are doing on Avastin, because we know Avastin's main effect seems to be on the kidneys. We are also looking for evidence of a low white cell count, which might be an indication that you've got an infection on board. And finally, we're looking at the hemoglobin level, so looking for anemia, because it might be a clue of some bleeding that's going on that we can't see from the outside.
The same question for your example, what you're looking for, and how made the results for treatment that day?
Yeah, so again, we check the urine, again, specifically looking for protein, because as I mentioned, Avastin can quite commonly cause the kidneys to leak protein. We're also looking for blood too, which again is a sign that the kidneys are sort of unhappy in some way. And both of those are Avastin effects on the kidneys.
And the same again for blood pressure.
So again, this comes back to the kidneys once again. So a high blood pressure, is a sign that Avastin is affecting the kidneys. So the kidney's response to Avastin normally is to increase your blood pressure so that it gets plenty of blood supply. If you have a low blood pressure, it could be something to look out for in terms of what Avastin's doing to the heart. So again, that's why we monitor those.
Thank you. And finally, why is it important to monitor people's weight while they're on Avastin treatment?
So that's because for antibody treatments, we give the dose according to your weight only. Unlike other, like chemotherapy agents that oncologists use, which the dose is calculated from both your height and your weight. So that's why it's important to have an up-to-date weight.
Okay, so once all of these tests are done and patients have an appointment with the consultant, either in the clinic or remotely, what other things would you like to check on during those appointments?
Well, I mean, broadly, what I'm looking at is to try and see how being on treatment affects the patient overall, and the balance of how it's affecting their life, how it's affecting the disease, and specifically to look out for any side effects of the treatment. So it's all of those things sort of bundled together, really. Sometimes it's a very quick, how are you doing? Yes, I'm fine, and it doesn't take very long. But it can be very useful, just sometimes people tell us about things that just make us think, oh, hang on, that's not right, we should think about that a little bit more closely.
Thank you. So assuming people get the green light treatment to go ahead, what can people expect to happen once they arrive in the treatment area?
Yeah, so you'll go to the infusion room, which is usually in the chemotherapy area of the hospital. At some point, sure as eggs are eggs, and I've probably done this too, you'll be described as being on chemo if you're on Avastin, which you're not, but it's simply a reflection of the fact that the place that you go to is the same place where a lot of the chemotherapy treatment is done. So that can be tough the first time you walk into that room, because you'll see people who look really quite poorly compared to you, and that can be tough. But once you get there, you'll find that the treatment will be given by a chemotherapy-trained nurse, because they're the people that have the most experience of giving these types of antibody therapies. So what they'll do is they'll introduce themselves, get you comfortable, find a vein, set up a drip, and it will be running with just saline to start with. And then they'll actually connect the fluid bag that contains the Avastin in it.
Thank you. So how do people normally feel while the infusion is in progress?
Well, normally you shouldn't really feel anything whilst it's actually running. The thing that the staff will be looking out for are signs of an allergic reaction. So they'll ask you about feeling hot or faint or any shortness of breath. But it has to be said that's fairly uncommon to get a reaction.
And next question is, how long does the infusion usually take?
Well, the first one they always give slowly to reduce the risk of getting a reaction, so it's normally over 40 to 60 minutes. But then after that, it can be sped up, so depending on the dose that you're on, somewhere between 20 and 40 minutes of the actual infusion time.
Thank you. We're almost finished now. I'd just like to quickly touch on the topic of COVID-19, as we've had quite a few questions on the patient Facebook group recently, with concerns about vulnerability to COVID-19 while receiving Avastin. So please could you help bring some clarity to that?
Yes, of course. I mean, it has been a very tough time because we've been very worried about the spread of COVID from patient to patient and staff to patient during this period. So we agreed some guidance during the first lockdown to space out the infusions for Avastin patients every 2 months for those patients where we felt we could do it safely. And for actually some of our older patients, we suggested pausing the treatment just on the balance of risk. In each centre, the NF2 nurses went through with the oncologists and the other consultants each patient and kind of worked out the correct priority for them. But I have to say, we know much more information now about giving treatments like Avastin to our patients. And in terms of risk, most NF2 patients will not really be at increased risk of complications from getting COVID if you're on Avastin. The only exception would be people who had some other pre-existing lung problems. And also we know that if you're on Avastin and you do get COVID, the Avastin itself doesn't increase your risk of getting a bad outcome if you actually do catch it.
Okay, thank you very much. I think we've been very thorough. But if anyone still happens to have any more questions, where do you recommend that they go?
Yeah, personally, I think it's best to talk to your team because I think they know you best. I think you can find a lot of information online about different types of therapy, but when it comes to the combination of using Avastin and in NF2 patients, it's so specialised. I think it's best to talk to people that know your individual circumstances. So that would always be what I'd suggest. You'll get good advice.
Okay, thank you so much. We finished now. It was really nice to see you, and thank you for giving such a clear overview of Avastin treatment in NF2. Thank you. So bye.
It's a pleasure.